Hello and welcome to this video on explaining how we do the respiratory examination. Thank you if you've watched the respiratory history examination. The intention for this one is to build upon that and is to provide students with an understanding not only of what they're doing when examining the patient, but why they're doing it and what the particular signs that come forward might indicate. However, before we get onto that, in the respiratory video, we mentioned that you had a chance to win this, the copy of MacLeod's Essentials of Examinations. And don't worry, we haven't forgotten about that. So we've done a random draw from everybody who commented on the previous video, and we'll give you the name of the lucky winner of that at the end of the video, so stay tuned. Okay, with that out of the way, let's start on discussing the respiratory examination. So your examination actually starts well before you get your patient sat down in your clinic or in your examination room. My examinations of the patient start when they're walking toward me down the corridor after I've called them into the room. The reason for this being is I get an opportunity to see how the patient is behaving, how they're walking, and what their breathing is like before they actually get into an environment where they're expecting to be examined. If you try it with a relative or friend at home, just say, I want to count your breathing rate, and then watch and see what happens. As soon as you say, I'm focusing on you, the person's approach changes. They become very aware of their body. As a result, that brief few seconds where the patient's coming down the corridor towards me, I get an unvarnished glimpse of how well they are, or not, as the case may be. Once the patient has come into the room, we get them sit down and comfortable. Again, I want to assess the person as a whole. So in terms of that short distance into the room, was it a difficult walk for them to do? Are they now short of breath after having sat down in my examination chair? Have they brought in an oxygen cylinder with them? Are they requiring supplementary oxygen in order to help them breathe? As I look at them, can I see any evidence of tar staining at all to their fingertips? And are they sitting upright, engaging me in conversation? Or are they in a posture such as tripoding, where they're having to brace themselves on their legs in order to engage their accessory muscles in order to help them breathe? With that in mind, it's going to give us a suggestion as to what we may find when we combine the information the patient gives us in the history from the information we begin to find during our examination. And I suppose that is an effective point for us to begin talking about the examination. So we've discussed broadly the end of bed examination, but we then need to focus to the hands. Now the hands are a wonderful window into a patient and their biological processes. There are so many signs that we can pick up here that may give us hints and clues to what might come later. To start off with, we get the patient to put their hands outstretched, and we're going to have a look over the back of the hands and see what we can identify. So beginning with the nails, we may see cholonychia, so spoon shaping the nails, indicating a patient with iron deficiency anemia. Now that's obviously going to be important in a respiratory patient, but if a patient doesn't have enough blood going around the body, they're not going to be able to carry enough oxygen, and that's going to impact on them as a whole. We want to see if there's any signs of yellow nails. Now, this is particularly rare, but I highlight it as a potential finding of lymphoma and some connective tissue diseases and possibly lung cancer, because it's different from the tar staining that we might see with a cigarette smoker. Although they do look similar, the yellow nail will be focused purely on the nail, whereas tar staining will affect the skin around the fingers where the cigarette is held as well. And I think it's important to highlight that we are dealing with tar there when we get that yellow staining from cigarettes, not nicotine, because nicotine is a clear, colourless substance, and that's a common area where students tend to drop marks in written exams. We're going to want to have a look to see what the patient's capillary refill is, so pressing on their fingertip and seeing how quickly it takes the blood to return. Anything about 2 seconds will be normal. And at this point we might notice a little bit of pallor to the fingers, so paleness in colour, if there was also any evidence of anemia. But there is several better ways to assess anemia on a patient, which we'll come to in a minute. Before we get to turn the patient's hands over, we get them to stretch them out in front of us and see if there's a tremor. Now, there are two types of tremors we may find with respiratory patients. The first, a fine tremor, which we could exacerbate or make clearer by placing a bit of paper on their hands. That would exacerbate any tremor that was there. The other is a coarse tremor, so an asterixis, where the hand is rhythmically beating when cocked back. The differentiation between these two signs is what caused them. So our fine tremor is normally due to medication use, particularly beta agonists, so salbutamol, the blue inhaler that most asthmatics are familiar with, or theophylline, another respiratory medication. In terms of the asterixis, that coarse tremor, that's a bad sign for a respiratory patient because it normally indicates CO2 retention and that they've got such a build-up of carbon dioxide in the blood vessels that it is affecting the brain, specifically those that are involved in movement. Turning the hands over, we may see pale palmar creases, which again is going to provide us with more suggestion that there may be problems with anemia here. We'd also want to check to see if there's any evidence of clubbing to the fingertips. In terms of checking for clubbing, we'd want to get the patient to put their fingertips together like so, to see if there's evidence of Shamroth's window. If we've got Shamroth's window present, then we know that a patient doesn't have clubbing. Whereas if it's absent, then it suggests that they have lost the connection between the nail bed and the actual skin over it, causing this sort of spoon shaping to the end of the fingertips. Now, there are many different causes of clubbing, and it's definitely worthwhile remembering those or learning those for the cardinal systems, so respiratory, cardio, abdominal, and possibly a little bit of endocrine systems as well, because they're very common questions for both written and practical examinations. Having examined the hands, we need to move upwards to have a look at the patient's pulse. Now, personally, I like to check both pulses at the same time because it doubles my chance of finding the radial pulse, which is quite an important thing when you're in the stress of an examination. But also it allows me to find another potential cardiovascular sign, that of a radial delay. In a healthy patient, we should expect the pulse to come to the wrist at the same time on both arms, but if there's a coarctation of the aorta, then we may get an irregularity between the two beats coming down the arm. When we're checking the pulse here, we want to check for rate and rhythm, so simply how quickly is the pulse going, and is it a regular pulse, an irregular pulse, are there any gaps or changes in the pulse? We have to check for the character at a large bore artery, either brachial or the carotid, because we need that large volume in order to be able to determine, is it a thin pulse, is it a thready pulse, is it a bounding pulse, and have we got any other variations in character, such as pulsus paradoxicus. Moving on up, at this point it would be useful to check a patient's basic observations, so do their blood pressure and also check their oxygen saturations, which can be particularly useful in our respiratory patient. Now, normally a saturation of 92% is considered to be normal. However, I personally get a bit anxious when I have a patient with a saturation less than 95. I want to know why their saturation is lower than I'd expect it to be. Similarly, once a patient's saturations are down to 92%, it's vitally important we work out what's going on, because that patient may need admission to hospital, unless they have an existing respiratory condition, such as COPD, where we change our boundaries for concern. So a patient with COPD would be happy to have their SATs down as low as 88% before getting seriously concerned. Now, when I do my examinations, I like to try and stay in a straight line. So I'll go up the arm, to the top of the head, down the neck, and down the body from there. So after having assessed for the blood pressure, I want to move up to have a look at the face. To start off around the eyes, I'm going to be looking for any signs of anemia, which we'll find by pulling the lower lids down and looking at the conjunctiva there. So far in terms of anemia, we've been able to look for colonychia, the spoon-shaped nails. We've been able to check for palmar creases, and now we've also been able to have a look at the conjunctiva of the eye. Now, there is a significant sign that we can see on the face, Horner syndrome, which has three cardinal features. There's ptosis, so the eyelid drooping down, along with enophthalmos, a sunken eyeball. We'll have miosis, so a shrunken pupil on the affected side, and similarly anhidrosis, an inability to sweat on the side of the body where the problem is. In terms of that problem, it's due to compression of the sympathetic nerves in the neck, often due to a cancer, preventing the normal functioning in the face. Having looked over the eyes, we need to have a look at the face. Around the mouth, we may see peripheral cyanosis, so blue tinging to the lips. Now, such as with Raynaud's, there are potential external factors, such as cold, which may cause blue tinged lips. However, blue tinged lips and central cyanosis, so the changing the underside of the tongue to a blue colour, will be highly concerning about a patient's oxygenation. Now, we've spoken previously about levels of acceptable oxygen saturations. If a patient has got central cyanosis, then we know this is normally associated with an 85 to 95% oxygen saturation level. To put it in another phrase, a patient must have between 3 and 5 deciliters of deoxygenated hemoglobin there. So what we mean by that is when oxygen is binding to the hemoglobin molecule in the blood, the two bind together to provide a red coloration. When the oxygen dissociates though from that hemoglobin molecule, it takes on a cyanotic colour instead. And that's partially why we have the classic colours for arteries and veins, with the artery carrying the oxygenated blood looking bright red, and in textbooks the vein carrying the deoxygenated blood blue, because of the lack of oxygen binding to the heme molecule, changing the colour. One of the key features to look at in the neck of both a respiratory patient and a cardiovascular patient is the jugular venous pressure, the JVP. In order to assess this, we must have the patient lying back at 45 degrees with their head relaxed on the bed behind. The reason being is the JVP from the internal jugular vein runs underneath the sternocleidomastoid muscles, which help us turn the head. If a patient is holding their own head, then that will keep the sternocleidomastoid muscles engaged and will mean that we will not be able to see the JVP waveform. With the patient relaxed and lying back, we can have them turn their head to the left to examine the neck. In a healthy person, the JVP may be not visible, or visible just above the clavicle, up to 3 centimeters in height. And we're measuring that 3 centimeters in height from the manubrial sternal angle up to where we're seeing the actual JVP itself. If there are reasons for a patient to have increased blood pressure or hyperdynamic circulation, then we'll see the JVP pulsation move up the neck. So things which might cause this would be pulmonary hypertension, COPD, And on the cardiovascular side of things, perhaps cardiac tamponade, which could be seen from respiratory causes such as a tension pneumothorax. The reason why these changes in blood pressure affect the JVP is because the JVP sits directly above the right atrium. As a result, the JVP can be considered as a manometer of the atrial pressure there. So what this means is anything affecting the atrial pressure will cause the JVP to increase. So for example, if a patient has an atrial myxoma, so a tumour in the heart, then that will cause the pressure to move upwards. If a patient has COPD with a hyperinflated chest compressing the heart, that will push the JVP up. But what happens if you have a patient for whom you would expect to have a raised JVP but can't see it? That may be because the JVP has risen so high it's gone up inside the skull and can't be seen. But in that situation, how do you determine whether the JVP is not visible because it's gone up versus not visible because actually the patient doesn't have a hyperdynamic circulation? We can perform the hepatojugular reflux, where we press on the patient's right upper quadrant, pushing blood up the venous system into the heart and moving the JVP up. In a healthy individual, if their JVP has not been visible because it's near the clavicular head, doing the hepatojugular reflux will then move the JVP up and have it visible. In a patient for whom we didn't think the JVP was visible because it had gone too high, we will not see a change in the position when we do the hepatojugular reflux. But there is always a way to work these things out in medicine. And if the JVP has gone so high up it's within the skull, we may see the earlobe waggling with each pulse, indicating where it is. Now we've mentioned that the JVP lies underneath the sternocleidomastoid heads, but we need to separate that pulse from the carotid pulse. And that's very easily done because the carotid pulse will be palpable, whereas the JVP will be visible, but when we place our fingers over it, we won't be able to feel it. Having checked the patient's JVP, we want to assess them for any lymph nodes. So for that, we need to stand behind the patient and then put our hands on the patient's neck from behind. So it's very important to tell the patient what it is you're about to do and gain their consent to do so, even though you've gained that consent already for your examination. The reason why we need to do this is otherwise you get the patient to sit up, you walk around the back of the patient, and suddenly hands come from behind around their neck, which could be quite startling and certainly not something we want. While placing your hands on the neck, you need to check for submental, submandibular, cervical, pre- and post-auricular, and also the lymph nodes at the back of the skull, the occipital nodes. To complete, we get the patient to shrug their shoulders up and then press our fingers deep into the supraclavicular fossa to see if we can feel any lymph nodes there. A lymph node on the left supraclavicular fossa may be Virchow's node. Now this is commonly seen in stomach cancers, but may rarely be associated with a lung cancer too. In terms of checking the supraclavicular fossa, it's actually easier than you may think. Shrug your shoulders forward now and just see how far you can push behind your own clavicle. It doesn't hurt, and you can actually press much further down than you may think. And that's the depth that we need to go to when assessing our patients. Now, our standard examination approach is inspection, palpation, percussion, and auscultation. And so far we've kind of been inspecting and then a little bit of palpation. We need to go further on the palpation now by checking for the position of the trachea. Normally we should find that sitting equally between the heads of the clavicle. But there are various respiratory issues which could result in the clavicle being pushed away from a problem or conversely pulled toward it. So as an example, if we get a tension pneumothorax where the lung collapses, but actually with every breath we get air leaking into the pleural cavity, causing that to expand with every breath, we're going to get increased pressure on the affected side, pushing the trachea away. If we have something such as a lung cancer, then that may both push and pull the trachea. Fibrotic lung disease, that can cause the pulling of the trachea. And similarly, a pneumothorax which doesn't go to a tension pneumothorax, that collapse will cause the trachea to be pulled toward the affected side. In terms of assessing the trachea, we want to put both fingers either side of the trachea, just by the clavicular heads, and we should be able to feel an equal pressure on both fingers. Be careful with this because it can be a little bit uncomfortable. Again, try that on yourself and you'll feel that it's not the nicest thing to feel in the world. If there is a deviation of the trachea, then we're likely to feel increased pressure at one or the other fingertips as we examine them there. With the trachea having been cleared, we then need to move on to examining the thorax, examining the patient's chest. So we get them to unstrip at this point, taking off their shirt, so we can have a look at their chest. And I like to perform an end of the bed examination again, looking for any structural abnormalities on the chest wall. So we may see hyperinflation, we may see pectus carinatum, where we get a very prominent sternum, or we may get a pectus excavatum, where we seem to have a central sulcus to the chest. In terms of these deformities, many people aren't too concerned about a hyperinflated chest. However, people can be very self-conscious when it comes to a pectus carinatum or pectus excavatum. I know a friend who's particularly concerned about theirs, and as a result, they're never happy to take their t-shirt off when even out in public with friends, so going to the pool and things like that. It's something to be cautious of during our examination to make sure that you don't make the patient feel self-conscious. We may see dilation of blood vessels in the chest if we've got a tumour obstructing the superior vena cava, impacting on blood supply coming down from the chest. At this point, I like to get the patient to take a deep breath in and out so I can watch the movements of their chest wall and see whether or not we have equal movement. Assuming everything is equal, I'm not too worried that I'm going to be finding a unilateral issue. However, if we go to the things we've already discussed previously, if we have a tension or a straightforward pneumothorax, that's going to affect one side of the chest moving less than the other. We similarly may see a reduction in movement if we have an empyema on one side, or any evidence of fibrotic lung disease which is impacting on the movement of the chest wall. When the patient does their deep inspiration, it's worthwhile paying attention to their face as well to see if there's any evidence of discomfort. If we have costochondritis, so inflammation at the chest wall, then that can be uncomfortable for a patient. Similarly, the presence of pulmonary embolism causing pleuritic chest pain would result in the patient expressing pain on that deep inspiration. So even these simple tests, when we're assessing the patient, can reveal a lot of very useful information. I like to formally assess the movement of the chest by placing my hands around the base of the patient's chest and asking them to breathe in once more. When checking the patient's chest expansion, we should expect our thumbs to move apart by at least 5 centimeters during the inhalation and then back again during the exhalation. And there I'm assessing, is the movement from the thumbs equal on both hands? So not only have I visually assessed the movement of the chest, but I've formally confirmed we've got equilateral movement on both sides. Once we've established that the patient has a normal chest wall movement, then we can go on to check for the apex beat. The apex beat is the position of the heart which is most inferiorly and where the heart is impacting on the chest wall. It's normally found in the mid-clavicular line, 5th intercostal space, and we'd normally put our hand just below the nipple on the left in order to be able to feel it. In thin people, such as myself, I can actually see my apex beat where the heart is impacting on the chest wall. If we've had hyperinflation of the lungs, if we've had cardiomegaly or left ventricular hypertrophy, then all of these things will result in the heart moving further down and round, so that a shift in the apex beat. Having assessed the chest wall, we now need to percuss over the chest. This is one of the areas that many students find very difficult at the start of medical school. To percuss, we're going to take our index finger or middle finger and we're going to strike over the middle phalanx of our middle finger. When we're positioning the hand, we want to place it between the ribs to transmit the force from our finger through, so we will get the sound reflected back to us. There is, however, one place during the examination where you can percuss directly onto the patient, and that is over the clavicle. If we've got a consolidation, a collapse, or an infusion, then when we percuss over this area of the chest, we'll hear a reduced sound coming through. This may be described as a dullness. Conversely, over normal lung spaces, we'd expect to hear a resonant sound when percussing. And finally, over a pneumothorax, we'd expect to find a hyperresonant sound. When percussing the chest, there are two additional conditions, a hemothorax and a pleural effusion, which can cause a specific finding called stony dullness. Both of these are where there's a liquid in the pleural cavity, and as a result, percussing directly over that will result in very little sound coming back. I've got an example here for you and see what you think. If you want to practice or simulate some signs you may get for percussion of the chest, get yourself a bottle of pop. Make sure you drink at least half of it. When you've got the empty space at the top, if you percuss here, you have a resonant sound, which is what you get over a pneumothorax. Conversely, if you percuss over the bottom, where there's still the fluid, then you have a dull sound, which is what you might see over an area of consolidation, such as an infection, or the collapsed lung of a pneumothorax. When doing percussion, as well as tapping directly over the clavicles, we need to make sure that our percussion lines are either side of the sternum and across the axilla as well. We'll percuss over the same areas as well when examining the back, but we'll need to make sure the patient crosses their arms over their chest to move their scapula away, so we have clear fields of lung to percuss. Having percussed over the patient, we finally get to get our stethoscopes out and do our auscultation. At all points during our auscultation, we want the patient to breathe in and breathe out through the mouth, giving us a good airflow to listen to. It's actually the turbulent flow through the large airways that gives us our breath sounds, and our normal breathing is considered to be vesicular. If we have issues with the consolidation, so for example a patient with pneumonia, there we're going to hear a different type of breath sound, specifically bronchial breathing. You can simulate bronchial breathing at home by listening over your trachea when you breathe in. That hollow blowing sound is one of the features that you'd hear over an infection. As well as this hollow noise, we may get crackles over any area of infection as the small airways open and close during the inspiratory efforts. There are, however, other crackles present in the chest. If a patient has pulmonary fibrosis or a pulmonary edema, then we'll get fine crackles. The difference here being that with pulmonary fibrosis, those fine crackles can be heard across the chest, whereas with pulmonary edema, those fine crackles are seen on the bases alone. Other chest sounds that we may come across are wheezes, which we associate normally with asthmatics and patients with COPD. This is due to narrowing of the small airways, giving a polyphonic breath sound. There is another breath sound similar to that called a stridor, which we're going to significantly worry about. A stridor is due to narrowing of a large bore airway and should be considered a medical emergency until proven otherwise. As a result, a stridor is an inspiratory whooping noise or whistling, which may be associated with a lung cancer affecting the large airways, or conversely a foreign body. This is often seen in children who may have inhaled a small toy, for example. Unfortunately, I'm going to spoil snow for you now. One of the other features that we can come across on the auscultation is what's called a pleural rub. If a patient has pleurisy, so inflammation of the pleural membranes, or potentially a pulmonary embolism, we get a creaking or rubbing sound. So it's considered to be the same as the noise you get when stepping on fresh snow. That as you crunch the snow for that first time. Now, I didn't really buy into that as a sound when I was first told about it. However, after hearing my first pleural rub, I'm now no longer able to think about anything else when I'm walking on snow for the first time. So when we talk about fine crackles, in the same way that you can simulate bronchial breathing by listening over your trachea, we can also simulate fine crackles by rubbing your hair between your fingers. That faint noise is the sound you'll hear with fine crackles. To complete our respiratory examination, in terms of auscultation of the chest, we'd want to do vocal resonance. Now, this is one area I'm particularly passionate about because it speaks to the history of medicine. The gentleman who first came up with this finding was German. And what vocal resonance is, it's listening to the voice of the patient transmitted through the lung tissue. So over normal airways and normal lung tissue, you'll get a slight muffling of the patient's words. Conversely, if you have a pleural effusion or you have consolidation, then you're going to get an improved transmission of the sounds through that tissue. In Germany, they use the phrase 99. Well, in German it's actually 99. And this is where an error has crept into classic respiratory teaching. In the UK, we've previously had patients saying 99. However, that is a different sound. It is not a diphthong as the word 99 is in Germany. The gentleman found when he got his patients to say a specific word, 99, he'd be able to hear the vocal resonance. However, classic teaching has had students getting patients to say 99. This is a problem because it is not the same as the original discovery. In German, 99 is 99, and hopefully you can hear the changes in tone there. 99 is a diphthong. It has both high and low notes, whereas 99 does not. Thus, having students in English use the phrase 99 doesn't provide the same diagnostic information as the correct 99 does. However, it would be slightly strange if in an English setting you started asking your patients to say German words. As a result, we can find another diphthong in English, that being 1, 2, 1, 2. If English or German is not your native language, I'd advise you to find diphthongs in your language which you feel happy to get your patient to say to you when doing vocal resonance. And if anyone asks why you deviate from classical teaching of getting the patient to say 99, you now know. To complete our respiratory examination, we'd want to check for any evidence of sacral edema at the base of the patient's spine. We'd want to check for peripheral edema at the inside of both legs on the border of the tibia, and also review any existing x-rays, sputum cultures, and, if possible, check the patient's peak expiratory flow rate, which we do by getting them to breathe into a peak flow meter. Right, well, I hope that this has been a useful review of the respiratory examination for yourselves, and I hope that you've been able to learn something. I think we've got a giveaway, haven't we? Yes! So, here's our MacLeod's Essentials of Clinical Examination, and the chap who's won this, his name should appear, hopefully, here. So, if that's you, drop me a line on Twitter at Dr. James Gill, and we'll organise a code for you so you can get one of these sent out to yourself. I really hope that this has been a useful video for yourself. If you'd agree, I'd personally be really grateful if you could give the video a like and consider subscribing to the channel. Doing that both tells me I'm not just shouting into an empty space, but also allows you to know when we've got the next video published. So given that we've pretty much completed the respiratory examination now, you've got the demonstration, we've done the understanding the history, and we've done understanding the examination. Which would you prefer us to focus on now? We've got the cardiovascular demonstration and the thyroid examination videos up. Would you prefer us to focus to the cardiac or the thyroid examination for us to look at understanding the examination next? Okay, I'll put a poll up here, hopefully, and if in doubt, drop me a comment in the down below, and we'll see what we can do to help you guys out. Well, have a good evening, and thank you for watching. Take care.